Up to 1 in 3 hospitalized patients with cirrhosis will develop acute kidney injury. For those admitted to the ICU, that rate exceeds 50%. The most severe variant of this condition carries a 90-day mortality rate as high as 80%. This specific manifestation of renal failure is becoming increasingly common, tracking in direct proportion with a nationwide rise in cirrhosis-associated hospital admissions. To reflect our evolving understanding of the disease pathology, the nomenclature has recently been updated. The rapidly progressive, volume-unresponsive condition, historically categorized as Type 1 Hepatorenal Syndrome, is now officially designated as HRS-AKI. Because untreated HRS-AKI is nearly universally fatal, the clinical goal shifts from passive monitoring of renal decline to the active identification of the hemodynamics driving the failure. The central paradox of HRS-AKI is that the rapidly failing kidneys are structurally intact. We know this because experimental studies have shown that if you remove the failing kidneys from a deceased HRS patient and transplant them into a recipient without cirrhosis, those kidneys immediately resume normal function. This is a purely functional failure. Biopsies of kidneys from patients with HRS-AKI show virtually no histologic damage, directly contrasting with structural diseases like acute tubular necrosis or ATN. The kidneys are not failing organically. They are executing a biologically appropriate, highly conserved response to a catastrophic systemic environment. They are the victims of a system-wide hemodynamic collapse. To treat the renal failure, we must force the diagnostic focus upstream, toward the liver. The cascade begins with localized tissue damage, advanced liver fibrosis, and the formation of regenerative nodules. This structural scarring creates severe intrahepatic vascular resistance. Blood struggles to flow through the fibrotic liver, resulting in portal hypertension. The body attempts to compensate by overexpressing vasodilatory substances, specifically nitric oxide and endogenous cannabinoids. This chemical response triggers a massive mechanical failure. Extensive vasodilation causes volumes of blood to pool within the splanchnic vascular bed. Simultaneously, portal hypertension increases intestinal permeability, allowing bacterial components to translocate into the bloodstream, triggering systemic inflammation and further vasodilation. Localized liver scarring breaks the body's systemic fluid distribution network. It creates a hyperdynamic, inflamed circulatory crisis that physically traps blood in the abdomen, starving the rest of the body of arterial flow. With blood sequestered in the splanchnic bed, effective circulating arterial volume throughout the body drops precipitously. Initially, cardiac output increases to maintain perfusion to end organs. But sustaining this hyperdynamic state exhausts the heart's reserves, leading to a decline in output known as cirrhotic cardiomyopathy. As mean arterial pressure falls, baroreceptors trigger the rapid activation of the renin-angiotensin-aldosterone system, the sympathetic nervous system, and the arginine-vasopressin axis. The cumulative result of activating these systems is extreme, progressive renal vasoconstriction. The body clamps down on the renal arteries, shunting blood away from the kidneys in a bid to defend central blood pressure. HRS-AKI is ultimately a sacrifice. The neurohormonal drive to maintain systemic hemodynamics completely starves structurally healthy kidneys of oxygen and flow. Recognizing this functional starvation clinically is exceptionally difficult. Due to extreme muscle wasting and poor protein intake, patients with advanced cirrhosis frequently exhibit a very low baseline creatinine, masking the severity of their kidney injury. The clinician's immediate diagnostic imperative is to confidently distinguish between functional HRS-AKI and structural ATN because the treatment pathways are entirely different. Nephrologists traditionally rely on the fractional excretion of sodium, or FeNA. In the general population, a FeNA under 1% indicates functional acute kidney injury, but advanced cirrhotics exhibit near-universal sodium avidity. Their kidneys fiercely retain sodium, meaning a 1% cutoff captures every patient, distinguishing nothing. This chart illustrates FeNA values across adjudicated diagnoses of AKI in patients with cirrhosis. It reveals that values for true HRS-AKI fall significantly lower than those for ATN. To cut through the cirrhotic baseline noise, clinicians must drastically lower the threshold. A FeNA value below 0.2% accurately identifies a patient whose kidneys are functionally starving. Many cirrhotic patients arrive heavily managed with diuretics. These medications alter sodium excretion and skew FeNA readings, requiring a separate objective measure of structural integrity. Neutrophil gelatinase-associated lipocalin, or NGAL, provides that objective measure. It is a novel biomarker released into the urine exclusively in the setting of overt structural tubular injury. This graph compares urinary NGAL concentrations across the different forms of acute kidney injury. We see a stark step function increase in patients with confirmed ATN, while concentrations in PRA and HRS patients remain exceptionally low. The clinical data establishes a strict boundary. An NGAL value of less than 220 nanograms per milliliter strongly points away from ATN, confirming functional HRS and predicting a much higher likelihood of responding to targeted therapy. By combining a recalibrated FeNA below 0.2% with a sub-220 NGAL score, clinicians obtain the data-driven proof needed to rule out structural damage and safely commit to aggressive hemodynamic reversal. The foundational treatment strategy is mechanically reversing the root pathology. We must squeeze the splanchnic vascular bed to force sequestered blood back into systemic circulation. The newly FDA-approved first-line agent for this in the United States is terlipressin. It is a vasopressin analog engineered with a highly specific affinity for the V1 receptor. V1 receptor agonism translates directly to intense, localized vasoconstriction. It selectively targets the dilated splanchnovascular bed, compressing the vessels and shunting blood out of the abdomen. This vasoconstrictor is paired with intravenous albumin. As the splanchnic bed constricts, albumin expands central fluid volume. Mean arterial pressure rises, the neurohormonal response subsides, halting renal vasoconstriction and restoring kidney blood flow. This precise mechanism is highly effective. In the confirmed trial, terlipressin achieved a 32% verified HRS reversal rate, demonstrating clear superiority over legacy off-label combinations. Terlipressin rescues the kidneys because it directly engineers a reversal of the systemic collapse. Forcefully squeezing the splanchnic bed is the only pharmacological mechanism capable of restoring central hemodynamics. But the confirmed trial data also exposed a critical caveat. The exact mechanism that rescues the renal system carries a hazardous paradoxical risk for the rest of the body. Patients in the treatment arm experienced a significantly higher incidence of severe respiratory adverse events. The combined administration of terlipressin and intravenous albumin rapidly expands central fluid volume. If the patient's cardiopulmonary system is already compromised by cirrhotic cardiomyopathy, this rapid influx of fluid can quickly flood the lungs, causing acute pulmonary edema. This establishes strict patient selection boundaries. Clinicians must exercise extreme caution in patients with baseline creatinine levels of 5 milligrams per deciliter or higher, or those exhibiting grade 3 acute on chronic liver failure. Daily volume assessments are mandatory, and albumin must be held immediately if respiratory compromise appears. For patients who fail pharmacological reversal or who arrive too hemodynamically unstable to tolerate it, the only remaining option is continuous renal replacement therapy. Initiating dialysis in this population presents severe ethical and statistical realities. RRT does not address the underlying end-stage liver disease. If a patient is not eligible for a liver transplant, dialysis acts as a bridge to nowhere, carrying a short-term mortality rate exceeding 90%. Treating this condition requires a razor-thin balancing act. Pushing massive fluid volumes back to the heart can save the starving kidneys, but it can easily drown the lungs. Clinical response to vasoconstrictor therapy correlates directly with the severity of renal failure at the time of initiation. As baseline serum creatinine rises, the likelihood of reversal drops. Achieving a response requires starting definitive therapy before the functional decline is too advanced. Practitioners must rapidly phenotype the acute kidney injury. Utilizing recalibrated FeNA thresholds and NGAL cutoffs allows clinicians to confidently rule out structural damage and immediately commit to a treatment plan. In the narrow window of HRS-AKI, diagnostic hesitation is fatal. Immediate objective identification and aggressive hemodynamic reversal is the patient's only bridge to survival.